you very much, Cressida. Kia ora koutou and mihi mahana kia koutou. So very warm greetings to you all. It's such a pleasure to be in front of an AIMA audience again. I was first invited to speak by AIMA in 2008 at a conference down in Queenstown in the South Island of New Zealand. And that was a really life-changing event for me and my wife Meredith, and began an international campaign to try to bring humanity and compassion to healthcare. And I think we've been to 5 or 6 AIMA events over the years. So we felt very generously supported and welcomed by all the folks at AIMA. So wherever you are in the world, thank you so much for giving up your evening and spending some time with you. What I'd like to do first is actually teach you how to do self-havening, because this is such a simple practice. And if you do it while you're listening to me speak, it's going to put your brain in a state of mind where you're going to be much more open and receptive to learning, feeling really calm and relaxed. And I'm going to lead you through quite a bit of the science behind havening. But before we do that, I'm going to show you a video of a live demonstration of a havening technique in someone with a really serious trauma that's dissolved away in about 15 minutes. So I'm going to introduce you to the technique. So it's a soothing stroking of 3 parts of the body. It's on the palms of the hands, and you can do it like this, or you can do it backwards and forwards. You can kind of get into a rhythm. Don't let your hands drop down, because if you rub your hands when they're hanging down, it feels a bit anxious, and the energy is much better if you do it up here. And all these forms of touch are intuitive. And I'm going to share with you the extraordinary science of how this affects our brain function. And so that's the first touch. The second one is a downward stroking on the upper arm. And this is actually the empathetic touch. When we want to reach out to give support to someone, we touch them on the shoulder, the upper arm, often with a little stroke. But make sure you don't rub up and down. That's not right. It has to be always a downward stroke. And the third form of touch is to the face, across the forehead and down the sides of the face. If you're worried about coronavirus and touching your face, you can leave this off if you like, or you can just clean your hands, wash them with soap and water, or use some alcohol gel. And then across the cheeks, which is easy to do without your glasses on. And I do recommend that you, wherever you are in the world, sitting watching this, that you continue to do this self-havening touch, because within about 30 seconds, it radically changes your brain state, and it really enables a brain state in which you're open to learning and feeling calm and relaxed. So, so I'm going to just remind you from time to time just to continue this, and it creates a collective energy field, which is really calm and nice. So what I'd like to do this evening is I have quite a lot of information to present. I'm going to give a brief introduction to havening. I'm going to introduce you to Dr. Ronald Rudin, who's the developer of havening. He's a medical doctor in the USA, an internal medicine specialist, runs quite a big clinic in New York, and he's been researching this for nearly 20 years. And I'd really love to bring his presence and voice to you this evening. So I'm going to show you a very brief video, and he's become a colleague and close friend of mine. And a little bit of introduction about havening and what it is in the context. Then we're going to go straight into a video of a live demonstration, which I did with a client in front of an audience. And she's very generously given permission for that to be shared with us all tonight. And then, being rather startled by what you see in that video, I'm going to lead you through some of the science that underpins this practice, which to me as a medical practitioner is really completely extraordinary to learn. And basically, we have a molecular mechanism in the brain which can delete a severe trauma in about 15 minutes or so, sometimes just 5 minutes. And we know a lot about the neural pathways and the molecular mechanisms. And I'd like to go briefly over that just so that you have an idea of the extent of science that underpins this practice. And then I'm going to talk much more clinically about the kind of cases where havening is helpful. I'm going to give some descriptions of clients that I've seen and the kind of presentations they've come with and how they responded. Again, as a medical practitioner, is extremely surprising to me. And then we'll open up for lots of questions and answers, because I think people are going to be quite fascinated by this, and there will be a lot of questions. And particularly if you're working in the GP world, primary care, the kind of patients that are the hardest to deal with anxiety, with depression, with chronic illness, with recurrent symptoms from which you have no explanation, for stress-related disorders, then havening has enormous promise for that. So I'm going to just pause for a moment. I'm going to share my screen to a PowerPoint presentation, and bear with me if there's any difficulties with that. So here goes. Great, it worked. All right, I'll minimize that. Yeah, so havening techniques is the proper name, and that name is protected. It's copyrighted. So, so these are the self-havening techniques that I just mentioned to you: the rubbing of the hands, the arms, the face. And the biology behind this is that only in 2013 is the first scientific paper published showing that the neuroscientists discovered a new class of C fiber sensory nerves in the skin. And these nerves only have one job, and that is to recognize a soothing touch. And if you put an electrode in that nerve and measure the impulses, you get the maximal impulse if there's a gentle stroking at a certain rate. So if you go too fast, it doesn't signal. If you go too slow, there's no signals, and it works better with a warm object. And this is part of our soothing therapy system, and these nerves are hardwired into our emotional centers. And one of the things that they do in the brain is that they completely change the frequency of the brain waves. So I have my own brainwave monitor. It's called a focus band, and it measures my EEG. And there's two screenshots there from the app on my iPhone. And the one on the left, before havening, I'm meditating and my brain's very quiet. And across the screen, those different colors represent different frequencies of brain waves. So on the left is the delta waves, all the way through to the right, the gamma waves, the high frequency waves. And then I begin havening touch, as just exactly as I'm doing now. In fact, I'm even wearing the same jumper as I was in that demonstration. And you can see that's a snapshot 31 seconds later, and there's a dramatic increase in the amplitude of delta waves. And as a medical practitioner, to witness for the first time was very astonishing for me. It certainly was never taught in medical school that a very simple form of touch could dramatically change your delta waves. And this is part of how havening works. And that's why you're already, all of you, listening to this presentation in an altered brain state. So there are lots of different brain responses to this form of havening touch. As I said, it increases the delta waves. As we're going to learn, if there's traumatic encoding in the amygdala, that the AMPA receptors that hold those connections can be rapidly erased if we follow the right sequence of processes and create lots of delta waves. This really changes a lot of your brain chemistry. So within a few minutes, you're going to have increases in GABA, which is an inhibitory neurotransmitter, and serotonin, which is kind of the feel-good neurotransmitter. And this also allows for incorporation of new memories and new beliefs. And it changes the landscape of the brain from one that's really anxious and vulnerable to one that feels a lot safer. As many of you will know, the emotional state very profoundly changes our perception. So if we look at this picture, if you're feeling in a happy and vulnerable state of mind, you'll probably see it as a joyful picture of a boy playing with his dog. If you're of an anxious disposition, you might interpret this picture as a vicious dog about to bite and attack this young boy who's running away in fear. So our emotional state very much shapes our perceptions. And one of the things that havening does over time is greatly increase resilience and change perceptions and change what we call the landscape of the brain. Delta waves also have a major role in learning and consolidation. As adults, the only time that we have lots of delta waves normally is during deep sleep, also called stage 3 sleep or slow wave sleep. And deep sleep is strongly, it's a time of healing and replenishment, but it's strongly connected with learning. And if you put a university student in a sleep lab every night and interrupt his deep sleep, you'll find that his capacity to learn new knowledge will be greatly impaired. And interestingly, in small children, babies and toddlers, the predominant brainwave in that immature brain is delta waves. And the time in life when we form our most core beliefs about, am I lovable, am I loved, am I safe, is the world safe, am my relationship secure, those kinds of things, am I worthy, are formed early in life in those early relationships, the first few years of life, when the brain is full of delta waves. And in the havening state, we can radically shift clients' self-belief. So that's another part of havening. So it kind of all ties together in curious ways. The reason that we know how to do these 3 specific forms of touch is a neuroscientist called Melvin Harper got lots of subjects into the science lab, measured their EEG, and tried every form of stimulation to the skin, tapping, buzzing, stroking, to every part of the surface of the skin. And what he showed is that these 3 areas, the palms of the hands, the upper arms, and the face, were the areas that stimulated high levels of delta waves. Also the crown of the head, and many of you have seen babies being stroked on the crown of the head, and they, you know, if you have a baby that's upset and crying, and you stroke them here, pretty soon they look a bit kind of hypnotized, and their muscles relax, and they become very relaxed and calm, and the crying stops, and they fall off to sleep. But we tend not to use that so much in adults because it messes up their hairstyle. But with some bald clients, it's kind of nice to do this as well. So this is the results from Harper's study showing that different parts of the body have different sensitivity in terms of creating delta waves. So the cheeks, and most people are very sensitive, increase the delta wave amplitude by about 90-fold. The shoulders and the upper arms up to 38-fold, the palms of the hands. And there's lots of points that make no difference. And the meridian points are not in any way connected to the generation of delta waves. Lateral eye movements that we use in EMDR is actually quite a powerful way of creating delta waves. And part of that may be because the extrinsic eye muscles are sitting right under the brain and they're oscillating backwards and forwards. So that might be part of the reason, but it's something that we use in havening as well. So the kind of conditions that havening touch is really good for is severe anxiety disorders and panic attacks. People coming to you with a lot of relationship problems and low self-worth, a whole variety of phobias, those who are haunted by traumatic memories, severe depression, PTSD, addictions, because Gabor Mate would say that just behind just about every addiction is trauma. So if you treat and delete and cure the trauma, the motivation behind the addiction often fades away. And chronic illness, and interestingly, chronic pain, and I've seen a number of cases of astonishing changes in chronic pain. And even some clients that report that major allergies are disappearing, which is really curious. But there are some of the havening practitioners don't work with trauma at all, and they just work with high performance athletes, Olympic athletes and executives, and they're using it to enhance coaching and performance because they're removing the subconscious blocks to the highest performance. So in context, it's a very powerful standalone therapy. I'm a medical practitioner and anesthetic specialist, and I don't have any training or background in therapy or counseling or psychotherapy or psychology, etc. So havening can be used alone as a very powerful standalone therapy. And I'm supervising a number of trainees and just really astonished and amazed at the results that they're getting when they share their case histories with me. It does beautifully integrate with all the knowledge that you already have. So if you're using NLP or hypnotherapy or psychology or body work or EMDR, it'll either integrate with those, or the EMDR practitioners that study havening now pretty much giving up EMDR and finding that havening is 3 or 4 times as fast. And in Raglan, where I run training courses, I'm really excited because we've begun to train some Maori participants, including our local kaumata. So we're just beginning to explore how havening might relate to some of the traditional methods. So that's exciting. And it can be used as a self-therapy for building your own resilience and well-being. So in general terms, there's 3 different kinds of therapies for mental distress. There's talk therapy, such as psychotherapy. There's a whole range of pharmaceuticals, psychopharmacology, and havening sits within touch therapy, what we might call a psychosensory therapy. And some psychosensory therapies are very good at stress reduction, like yoga or exercise, music, aromatherapy, massage. These are non-specific, so they're not being used to target a specific trauma, but they're good for increasing well-being and resilience. And the havening falls in the camp of the specific therapies like EFT, tapping, EMDR. And that's how havening came into being, because Dr. Ronald Rudin, the founder of havening, saw a demonstration of tapping by Paul McKenna in the UK, a famous stage hypnotist and therapist, who apparently cured a severe phobia in about half an hour in a demonstration on the stage. And Dr. Ronald Rudin was absolutely, as a medical practitioner and PhD researcher, was fascinated to try to figure out what was happening in the brain. How can a trauma be removed from the brain in just 30 minutes? So he began researching how does tapping work? And after some years, he discovered that the creation of delta waves was really important, and tapping certainly does that. So it's really evolved over the years since then, and he's evolved a number of different techniques and processes with the havening touch that are dramatically more effective and quicker at deleting trauma. So I'm going to introduce you to Dr. Ron Rudin now. So I'm just going to switch my screen share. Right, I found the video, so we'll click on it and maximize the screen. And hopefully the sound will come through well for you.
Hi, I'm Dr. Ron Rudin. I've been an internist for almost 35 years, seen a lot of stuff. Each day, though, is a new learning experience, and I tell my young doctors, never decide not to see a patient. You will always learn something new. It is one of the great joys of medicine that the body presents problems in ways which are sometimes truly baffling. And it is the ability to solve puzzles and these things in a non-linear way, which makes someone to be a truly great doctor. This approach, which we call havening, which means to put into a safe place, we started around 2002, 2003. It is a technique that uses mostly touch and distraction to generate these electroceuticals, and these electroceuticals alter the way the brain functions. But it is so fascinating because what we can do now is not doable by Western medicine. We can cure illness, not just treat it with medications. We can cure it, and that occurs by a neurobiological process, which is called in very complex terms called synaptic depotentiation, which means we take the on-ramp of this memory, which we bring to conscious awareness, and we block it so that the memory no longer is accessible to us. And once that memory is no longer there, the chronic and inescapable stress goes away. And so we now have access to the brain in a completely different way. It's safe, it's gentle, it's rapid. It's a little art, it has some art form to it because you need to be able to find the historical background in the person's mind. But often once we find this, we can then easily and rapidly remove that inescapable stressor and thus free the individual from the chains of remembrance, and hence the pain.
Right, I'll just find my presentation again. Right, so this is, so you saw him applying havening touch to a client. So rather than doing the touch to yourself, the practitioner can apply it. Or if we're doing a session by Zoom, then the client would be doing the havening touch to themselves and the practitioner would be havening touch at the same time. So what I want to share with you is the protocol we use for deleting a particular traumatic event, because you're going to see this demonstrated in just a minute in a live demonstration in a video. So what we do is we ask the client to briefly recall the traumatic event. They don't have to tell any of the story, which might be very traumatizing or painful or humiliating. So they just recall it very briefly for about 30 seconds or at most a minute. And what that does is it activates the nerves in the amygdala precisely that are holding the encoding of that trauma, and it depolarizes the nerves. So then we can work on that nerve junction. And we ask the client to give us a score for how distressing that event is, using a score from 0 to 10 subjective units of distress. And you'll hear the client doing that. And then we begin havening touch. And because we don't want the client to be thinking about or remembering or reinforcing that trauma, we use a variety of distractions. So we get the client thinking about lots of other things, by getting to count backwards or remember happy events or sing songs or all sorts of things. And we do this together, the havening touch and the distractions, for 5 to 6 minutes, because that is the amount of time that molecular reaction occur that can delete those nerve connections. And then we ask the client to recall the memory again. It reactivates the nerve circuits that encode the trauma. But by that time, the memory is beginning to fade. It feels less painful. So we get a new score, and we repeat cycles like that until the score has gone 10 to 0 and all the distress has disappeared.
Yeah, so when I was about 21, I was horribly raped, but also as a child, I was also really abused. So I actually wanted to address the really early childhood.
Just for the purpose of illustration, or we could do that adult event, because I mean that would be thematically linked, and often just as a safe place to start, we start with a more recent event. So would that be okay? Okay. What I'd like to do is just demonstrate the touch to you and just make sure that you're okay with that. All right? Can I do that now?
Totally.
During the therapy, I'm not going to sit in front of you because I don't want you to feel as if you're trapped. So I'm going to sit to the side of you. Now, may I come a bit closer?
Sure.
Okay. So would it be okay if I touch your hands? Can you rub your hands? So can I demonstrate it? So it's just a really soothing touch, and just a reminder, the purpose of this is to create lots of those nice healing delta waves. Okay? Because that's the brainwave movement. Is that okay for you? And you can keep your eyes open at the moment, whatever you prefer. May I move it closer?
Yeah.
Okay, so I'm going to do the therapy from here. And may I touch your arms?
Yes.
Okay, so this is kind of the empathetic touch, isn't it? It's just a soothing touch. What I'm going to ask you to do is just pull your hair behind your shoulders, because I don't want to be pulling your hair. Okay, that's great. And is that okay?
Yep.
All right. And then move just a little bit forward.
Sure.
May I touch your face?
Yes.
Okay. So it's just a soothing touch from the forehead and down the side of the face. And we also come onto the cheeks, if that's okay. Is that all okay? And again, these very specific forms of touch, the purpose of them is to create lots of delta waves. Alright. So what the sequence is going to be is that I'm going to ask you to just very briefly recall that event at age 21. Just for 30 seconds or a minute, no more than that. Okay? And I want you to just place yourself in the time, the context, the thoughts, the feelings, the emotions. I think it's going to be pretty present for you. I think it's present already. Okay. Can you please give me a score from 0 to 10 for the distress of that event, where 10 is the most distressing and 0 is completely relaxed? Would you like a tissue? No? Okay. Obviously pretty distressing.
10.
10. Right, okay, we're just going to step straight into the therapy, because I want you to be calm and relaxed, okay? So would you like to rest your hands down? Okay. So we're going to use distractions, so I don't want you thinking about that story anymore. So I'm going to do some weird things. So we're going to go into a superstore, and you're going to do alphabet shopping, and you're going to fill the trolley with things beginning from A to Z, food or any other items. Apples?
Apples, bananas, cherries.
Good.
Dogs.
Would you like to keep your eyes closed? Yeah. Okay, good.
Eggs. Fish.
What comes
What
to
comes
cheese?
to you?
Yeah. Having interferes with brain function, so that makes it difficult. Yeah,
grapes, horses,
yeah, I can help you out if you
ink.
want. Yeah, good. What do kids like at a party?
Juice,
Jelly.
kites,
Mm-hmm.
lemons.
Okay. We'll let you off that one because you're doing really well. All right, we'll take you into the kitchen. I want you to prepare a dish for me. So you're going to be a TV chef and you're going to tell me about all the ingredients and what you do to prepare this.
I can't.
Better than you like. All right. All right. If you can make the client laugh,
I
it's
make
even
good
better.
egg.
All right. Okay, we'll choose a different one then.
I'll make you some eggs if you
Okay.
like. Yeah.
All right. Tell me about your most joyful practice.
My joyful practice.
Yes.
My most joyful
Practice. Yeah.
practice is just to sit and go inside and feel my joy.
Mm-hmm.
Oh.
No? And how did you learn to do that?
I learned that when I was 17 through a really wonderful person called Grandmother.
Mm-hmm. Yeah.
And
So you've been in Liberty for quite a while?
he's just my teacher.
Mm-hmm. And what's the nature of his teachings?
The nature of his teachings are that he shows you a really simple, practical way to feel the joy that's inside.
Mm.
Yeah.
Mm-hmm. Yeah. And what does that feel like when you sit in that space?
It's fantastic.
Mm-hmm.
It's yeah, more than I could
And
imagine.
how does your body feel when you're sitting in that state?
Very happy.
Oh, relaxed. Mm-hmm. Okay. All right, how's your body feeling at the moment?
Pretty okay.
Yeah, all right. Okay, take a couple of the breaths. Okay, good. I'd like to just keep your eyes closed and listen to my voice. Go back to that story again. Let's see how it is now. What did this school have to do? Maybe the menu has changed a bit too. It's a little bit of a Alright. Well, tell me a lovely story.
A lovely story.
Yeah, tell me a lovely story about one of your mums.
Well, just I guess really just experiencing and watching people transform
Yes.
from women to mothers and
Yes.
yeah, just that's yeah, and that often happens and that's
Mm-hmm.
a big joy.
Mm-hmm. Lovely breaths.
Pardon me.
Alright. And just go back to that memory again and see how that is now.
It's okay.
You can open your eyes now if you like. This one might take a little moment just to kind of come back to the present, because being hidden is a bit like being in a deep dream, but it's kind of nice. So can you share with us a little bit about how the memory might have changed or how feelings have changed? What's different for you now?
It's almost as if how is it? It just feels like it's kind of way. It's away.
Yeah.
Yeah.
So distant.
It's hard to kind of even put into words, but it's like it's kind of way back over there.
Yeah. So when we started, I mean, you know, pretty much at the mention of this, and thank you for being so courageous for bringing such a distressing event to the room today. I mean, you got very tearful and very upset, almost in kind of the first sentence. So how does it? What's the contrast between that and memory? Because you couldn't mention it without getting very tearful. How does it feel now?
Well, it feels like it's something that happened to me.
Yes, so you know, effectively.
but I can kind of put it into a really little box and just kind of forgive and move on.
All right. Thank you so much. Can we relieve you if you would you like a hug?
Do you want a hug?
So this is what we often see in Havening. Someone starting very distressed. She described an event where she was horribly raped at age 21. And within a few minutes, you see the distress diminishing greatly and the energy of the client changing. And then we've done about 15 minutes of Havening altogether, if you looked at the elapsed time on the video. And then when I asked her to recall the memory, she looked quite puzzled and she didn't really know what to say and felt as if it was something very distant from her, something she described later on that it's like it's firmly in a little box, a very far distance from her, can never hurt her again, and that she can remember that event with forgiveness. And that's the kind of reaction we commonly see. So what I'd like to do now is share with you the science of what was happening in this lady's brain while we were doing the Havening, because we know quite a lot about how that's working. So I'm just going to go back to the PowerPoint, and fingers crossed we'll be able to find the right PowerPoint file and not have more fun and games. Okay. Right. So, why on earth do we have traumatic memories? What is their function? What part of the brain is involved? What's happening at a molecular level when we get traumatized, and the neurophysiology of that? And how can we erase traumatic memories so quickly in just a few minutes? And how does Havening work? So why does trauma exist? The reason is that the world is dangerous. And we have multiple mechanisms to keep us safe. So we have, for instance, reflex responses. So if you accidentally touch a hot top of a stove, we'll pull our hand back extremely quickly and protect ourselves. If we get something down the wrong way in the airway, we'll cough and choke. If there's a sudden sound, we'll duck as if the missile might be coming. So these are all responses that we have to protect ourselves against physical threats. We have an immune system that protects us against infections and foreign bodies. And we have an emotional system which has a fear and anxiety response to potential threats, including learned threats. And the characteristics of all these systems is that they produce very rapid automated responses, and they all include learned responses. All these processes have memory. So if we take the immune system as an example, the first exposure to infection creates a molecular memory and a cellular memory. And thereafter, there's a continual scanning surveillance 24/7 and a very rapid automated response to reinfection, to that learned threat. But the immune system can become overreactive when we get allergies. It can cause collapse in anaphylaxis, and it can start to attack self in autoimmune disease. And the way the amygdala and the emotional system works is very similar to that. So the amygdala is a bit like an emotional immune system. It remembers threats in very great detail. It's a continuous surveillance system. There are vast amounts of sensory information coming into our brain, of which we're only conscious of a tiny fraction. And that subconscious information is being fed through to the amygdala to see if it matches up with any remembered threats. It's immediately responsive. We get an emotional response to a trigger within seconds. It can become very overreactive, so clients with anxiety disorders, panic and phobias, and it can cause collapse, either with PTSD or with overwhelming collapse with the dorsal vagal system. And it can also attack the self, because a lot of my clients have very deep feelings of shame and self-criticism. And trauma is hardwired in the lateral body of the amygdala. So during a traumatic event, we get hardwiring of all that information in a matter of minutes. So most of you are familiar with some basic neuroscience. The amygdala is where all the action is happening. The thalamus is like the postal sorting office for all the sensory information. So the thalamus takes this sensory information, and some of it passes straight to the amygdala, and some goes to the cortex and gets evaluated and then comes back to the amygdala. So these are primitive parts of the brain. These are primitive survival reflexes that are happening. So what happens in the brain when we get traumatized? As I explain it to my clients, we get a hardwired traumatic memory, which is a bit like a multimedia image. So every element of the scene where this trauma happened, the context, the setting, all the information that comes through our senses, the sight, the sound, the smell, the touch, the taste, all of these things get encoded, hardwired as part of the traumatic memory. And then our internal responses, our emotions, our stress responses, our body feelings, our body posture, and pain, all of those get encoded and hardwired as part of this traumatic memory, ready to be triggered very rapidly. So it's like a multimedia web image. And this is a newspaper heading of a shooting, a very traumatic event. And on the page, you can see images and video and sound links and stories and context and links and tags. And the amygdala very much stores information in the same way as a computer does. So all of the videos and pictures on that newspaper page there, they all have links called href, which is the computer code that links to that particular image and puts it on the page. And the amygdala encodes all the components of a traumatic memory in a very similar way. They're hardwired in new nerve connections. So this is where the action is. So the first synapse of the sensory information that comes through the thalamus into the lateral body of the amygdala, there's a synapse there, and the neurotransmitter is glutamate, and the receptors that encode the trauma are called AMPA receptors. And there's a variety of other receptors as well, and voltage-gated calcium channels and different mechanisms going on. But this is where the action is for trauma. So what the traumatic memory does is it links certain sensory triggers are hardwired to a traumatic response. So the traumatic response includes the emotions, the stress responses, and so on. So this pathway from the sensory information is hardwired all the way through the brain to the output of the traumatic memory. And it causes an automatic reaction activation of powerful emotions and physical stress responses and physical symptoms, which can include pain and a whole variety of other physical symptoms, such as tension or pressure. And what havening does is it severs the link. So there's no longer a connection between the trigger, which is the sensory information, and the outflow of the traumatic memory. So brainwaves, as you know, have different frequencies, and during fear and trauma and stressful events, we fill our brain with gamma waves, which are very high frequency waves. And during the healing reaction and during deep sleep, we have delta waves, which are very slow brain waves from less than 1 cycle a second up to about 3 cycles per second. And this is what happens during traumatization. There's a mechanism within the postsynaptic neuron, which is frequency sensitive. So we have very high frequency gamma waves. The enzymes within the cell are frequency sensitive. They notice an oscillation of calcium levels within the cell, and a whole pile of AMPA receptors are fed up to the surface of the nerve cell, and then they're locked in place with a phosphate bond, and they're immutable. They'll be there for the rest of your life. That trauma will be encoded. My world record for that is havening my mother on her 90th birthday for a trauma that occurred on her first day at school when she was age 5. So she had these hardwired traumatic encoding in her brain for 85 years, and 10 minutes later, we'd actually remove those receptors. So this is the mechanism that occurs during trauma. If we activate that nerve connection and then create delta waves, so this is what happens. So because we have lots of new AMPA receptors on the postsynaptic membrane, we've got this hardwired connection between the sensory signal and the automatic outflow. If we activate the trauma and depolarize those nerves and then create lots of delta waves with havening touch, then the voltage-gated channels cause a slow frequency oscillation of calcium within the cell, and the enzymes, which are frequency sensitive, reverse the mechanism. So a phosphatase gets activated that dissolves away the phosphate bond, and then the receptors are endocytosed into the cell. with clathrate and dynamin. And this molecular mechanism works in 5 to 7 minutes. And this is the mechanism underpinning havening. So now the result is that having removed the receptors, we get the sensory triggers still, but they don't trigger any response at all because the nerve connection is broken. So we don't get any emotional responses or stress responses or somatic responses. We do still recall the objective facts of the memory because they're stored in a different part of the brain. So the factual information remains, but all the images, the video, the sounds, and all those kinds of things are dissolved away. So Dr. Ronald Rudin 2 years ago published a detailed scientific paper that elaborates all of the molecular mechanisms. And this makes havening unique among all of the psychological therapies. And I want to just talk you very briefly through some of that detail. So during encoding of trauma, we've got all the sensory information coming through the thalamus. Some of it is relayed through the cortex and then back to the amygdala. There's high frequency brain waves. You get depolarization of the synapse. The high frequency brain waves activate a voltage gated calcium channel so that the concentration of calcium ions within the intracellularly vibrates quickly, and the frequency sensitive enzyme, which is called calmodulin, it actually is activated by that high frequency calcium oscillation that activates a phosphokinase. So it pushes receptors up to the surface of the cell, and then the phosphate bond is pushed up and locks the cell on. So that's the mechanism during encoding. During havening, because we have low frequency delta waves, we depolarize the same nerve connection, but because of the low frequency brain waves and the voltage gated calcium channels cause a low frequency oscillation inside the cell. That's noticed by calmodulin, which is this frequency sensitive enzyme. It binds to calcineurin. It dissolves, creates a phosphatase that dissolves away the phosphate bond, and then the receptors get endocytosed into the cell and degraded. So that's the mechanism underlying havening. Now, during a traumatic event, there's different categories of sensory information. So imagine if you're in a bank robbery, there's a bank robber pointing a gun at you. So the gun is the fear-producing content. But there's also information, sensory information connected to that, which is not necessarily directly threatening. So for instance, the palaglava. So a client who's been in a bank robbery may have a phobia about men wearing balaclavas because it's a subconscious association between the traumatic event, even though a balaclava itself is not a threatening thing. And then there's the context, which in this case would be a bank. So the client might feel very anxious anytime they go into a bank. And these kinds of information enter into the amygdala by different routes, and this is part of the information that we have about how trauma and havening works. And then that leads to the 4 components of the traumatic memory. And we have more detail about which nerve signals travel to which subnuclei are within the lateral body of the amygdala, and which subnuclei then drive the different physiological and emotional responses. So every traumatic memory has 4 components. So there's a cognitive component, the story of the events. There's the emotional response, the anxiety, the fear. There's the autonomic response, the visceral responses, the activation of the sympathetic and parasympathetic nervous system, and also of stress hormones like cortisol, and somatosensory. So clients will encode in their body sensations aspects of the trauma. So for instance, one of my clients who'd been raped and held down by a man, after we cleared all of the emotions, she had a horrible feeling of tightness around her wrists and the neck, and then we havened that somatic element of the traumatic memory away. So this can include pain. So there are many clients with chronic pain where actually the cause of the pain is a traumatic encoding of the pain, even if they didn't have pain at the time of the accident. So a traumatic event is an intense emotional response, high frequency brain waves, change in neurochemical levels, It doesn't have to be you that's threatened. So if you see someone, your loved one, having a horrible thing happen to them, or even if you hear stories, so as health professionals, we may get secondary traumatization from hearing stories, and these can be encoded as trauma as well. And the traumatic memory is initiated either by consciously remembering that event or by subconscious stimuli, and that triggers within seconds this whole cascade of effects and the release of stress hormones. And what we further know in the theory is that a number of conditions have to be met for the encoding to take place, because two people can be in exactly the same car accident, car crash, and one will be traumatized and the other is not. And the difference between the two is that one is emotionally vulnerable and the other one is emotionally resilient. So a vulnerable landscape is one of the conditions. The event obviously has to have some kind of meaning or threat. And there's always an element of inescapability, that the client is either physically or emotionally or psychologically trapped in this circumstance. When those four conditions are met, then the trauma gets hardwired. And when we're taking a history from a client, we're looking for those conditions. So all of us are born as babies with a number of threats that are unconditional, innate, or learned. That includes abandonment, pain, heights, suffocation, being trapped, these kinds of things. And they can also be experienced vicariously. I'm sure this is a Photoshop picture of these small children, 200 feet above the park, but it provokes anxiety to look at it. And then some clients have a really vulnerable landscape of the mind, and some have a really resilient. And the ones who are resilient are much less likely to be traumatized. And again, this landscape shapes our perceptions very powerfully. So it changes our interpretation and meaning of events, and that's very personal. And inescapability, that sense of being trapped. So I want to give some examples of some of my own traumatic memories and some of the very obvious and sometimes subtle triggers that can trigger those unwanted feelings. So I was sent to boarding school at age 10, and that was a traumatic event for me that created a profound fear of abandonment. And if I was really in conflict with Meredith, my loved one, which would be uncommon, I would have this terror of abandonment and be really scared that she was going to leave me, even though that was a completely unrealistic fear, and she's deeply loyal and loving, and that never was going to happen. But I had an encoded trauma from age 10 that made me fearful of that. That's now been havened away and is completely gone. Going away from home alone, I was for quite a number of years doing locum anesthetic work, and I'd be away from home for a week or two. And the first day or two of a locum being away from home, I'd have this feeling of stress and sadness, which is actually encoded trauma from each new term at boarding school when I was separated from family again. As a junior doctor, when I carried a cardiac arrest pager, I had a lot of traumas about the pager going beep, 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 and I'd get a big fright and have to go and run and try and save a life. But in the doctor's cafeteria, there was a woman who operated the keys on the till, and the keys went beep, 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 beep. And she was just really fast on the keys, and she'd go beep, 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 like that on the cash register. And I'd get a fright, a fear response, and think my cardiac arrest pager is going off, and it's just the noise of the cash register. And then a really subtle one is that in recent times, I've been working at Thames Hospital in a day surgical unit, doing work that should be really relaxing for me. They're fitter patients, it's relatively minor surgery. I've been an anesthetist for more than 30 years. But each day at work, I unaccountably arrived with a feeling of anxiety and stress. And I didn't understand that till I thought really carefully and used my knowledge of trauma and realized that the 4 flights of stairs I climbed to get into the operating room were very significant, because as a junior doctor in my first year at work, when I had a lot of scary experiences in the operating room, I had to climb 4 flights of stairs before entering the changing room, and that got encoded as a trauma with that very specific, subtle subconscious link. And so when I figured that out, I asked one of my head-knee colleagues just to clear that for me, which she did in 15 minutes. And the next day I arrived at work with no anxiety. So we can probably all think of examples of triggers. So the consequences of traumatization, either acute or chronic, can be major depression, a lot of anxiety disorders, a lot of chronicity of reflective emotions, such as guilt or shame, whole variety of addictions, Obsessive compulsive disorder, although that's the one condition that seems to be really hard to treat with Havening, it's not very successful. Chronic pain and somatization, predisposition to PTSD, and a predisposition to a whole range of chronic physical diseases. And I'll share some cases with you. The first major randomized control trial of Havening is published on the 2nd of September this month. This is a study from the UK, numerous practitioners across the country, 125 subjects that were identified as having type D personality. That's a personality type with chronic negative affect and social inhibition. That carries a very high risk of chronic disease and mental illness, and also a risk of unhealthy lifestyles and a failure to adopt health-giving activities like exercise, and a tendency to ignore their doctor's advice and to take their medications. So there's a kind of triple whammy of chronic disease factors. These clients had one episode of Havening, 1 hour of Havening, randomized control trials, 65 in the treatment group and about the same number in the control group. Prior to Havening, they did a formal evaluation on a standardized scoring system for the diagnosis of type D personality. And prior to Havening, 59 out of the 65 subjects were confirmed to have a diagnosis of type D personality. The outcomes were measured 24 hours after Havening and 1 month after Havening. There were remarkable results at 24 hours, but the results were even stronger 1 month after Havening with no further therapy. The number of subjects in the treatment group that now had a diagnosis of type D personality that were above the threshold fell from 59 to just 9, and there was no change in the control group. In a subset of 40 patients, they measured blood pressure and cortisol 1 before and 1 month post-session, and there was a substantial fall in cortisol, and there was a remarkable fall in blood pressure average across the 40 subjects. The systolic blood pressure fell by about 15 millimeters of mercury, and the diastolic by about 10, which you'd appreciate is the kind of response you probably see from a first-line treatment, drug treatment for hypertension. So that's the first major trial of Havening, and that's from 1 session of Havening, really remarkable results. And that's in the Journal of Psychophysiology. So just running through just some of the kinds of cases that I see and the outcomes I've seen. A lot of patients, a lot of clients rather, with phobias. As an anesthetist, I see a lot of clients with needle phobia, but this is one client, a lady in her 60s, lived in Christchurch, had 8 years of severe earthquake phobia, frequent fear responses, hypervigilance. She had a geological map of the South Island showing where all the faults were, and if she was driving cross country, she would not drive on any roads anywhere near a fault. She would go all the way around. She couldn't drive through tunnels. There was going to be an earthquake and she'd be trapped and crushed to death, and they were unsafe. So when I asked her if she'd ever had this kind of fear before the Christchurch earthquake, she recalled that as a teenager, age 16, she'd been in an earthquake, and she described that as quite traumatizing, very scary. And I said, okay, that's probably when the encoding, the hard wiring got put in your brain, not during the Christchurch event. So we went back to that childhood, that teenagehood memory from 50 years before, and we did the event Havening process, and in less than 5 minutes, that was completely erased, and she couldn't recall any of the fear of that memory at all. When we brought her forward to the Christchurch major earthquake, that terrible event, she looked extremely puzzled because she simply couldn't connect any fear at all to the events of that day, and looked very puzzled. And I spoke to her about a month later, and I said, "Well, how's the earthquake thing going?" And she said, "Oh, I'd completely forgotten about it." And then I had a sharp intake of breath. "Last weekend, I was with friends. We went on a picnic. We went to Littleton. I drove through the tunnel. I didn't even think about it." So that's the kind of dramatic response we sometimes see in a client that's otherwise resilient, who's got one discrete trauma that we can erase. Chronic traumatic pain. Pain can be encoded. There's often an injury at the time of trauma. And we might suspect that chronic pain is traumatically encoded if there's pain in a part where there's no history of recent injury, where the distribution of pain is non-anatomical, it doesn't respond to conventional pain therapies. And where there's a history, this is where you're being the detective, like Dr. Rundin said, finding the history. Was there a severe emotional trauma going on at the time of the physical injury? If that was the case, then the pain may have been encoded as part of the trauma. And there's a whole variety: chronic back pain, neck pain, TMJ points, fibromyalgia. So within the Havening community, there are lots of reports of fibromyalgia being relieved by Havening, chest pains, etc. And I had a client, just an extraordinary case, a lady in her 40s. She's been 8 years on ACC. 8 years before, she had an injury to her right hand, which was fractured, and she needed surgery, open reduction, internal fixation. At the time that was happening, her husband, she found out that he had been having an affair, and then he left her to live with this other woman. She needed reoperation on the hand, which didn't heal up, and then a reoperation again. During that third anesthetic, she had anaphylaxis to the anesthetic and nearly died. So there was trauma upon trauma. While all this was going on, she discovered that her children had been, small children, a 2-year-old and a 5-year-old, had been sexually abused. So there was terrible emotional trauma, all connected to the time of injury to this hand. She began with chronic pain in her hand. It spread to her entire right arm and her shoulder, the right side of her body, and her right leg. At the time I met her, her right hand was completely paralyzed and useless, and she'd been on ACC for 8 years. And 3 years before, she had been bedbound and suicidal. At the end of the first Havening session, we relieved all of the pain in the right hand and got full function back on the right hand. She lives a long way away. She came back for 2 more sessions, and we reduced by 90% the pain in her leg. Now she's no longer on ACC. She's applying to university to do a degree and start a new career, and has full return of function. Panic attacks, you'll all be familiar with the features of those. This was a case quite recently. This is a poor lady who had she was referred to me 2 days before an elective Caesar by her counselor, because she was having panic attacks about the thought of going into the operating room and having another C-section. 2 years before, she'd had catastrophic complications, anesthetic complications during labor and Caesar. Her epidural block had failed to work. She needed an emergency Caesar. The anesthetist did a spinal anesthetic that failed. When the surgeon made the incision, she started screaming and could feel the pain. The anesthetist then converted to a general anesthetic, and she refluxed and got a pulmonary aspiration and ended up ventilated on ICU with an aspiration pneumonia. So it's just, she survived, and the baby was in good health, but she was having panic attacks about the idea of coming back to the operating theater. So on the Monday, I got her to my clinic, and we did one session where we erased the traumatic memory of the terrible events 2 years ago. And the next day she came back, and we went into the future, and we havened a story why she feels completely safe and relaxed about everything going beautifully well and her feeling calm and relaxed. And then on the Wednesday, she went to theater and remained very calm and composed in the operating room. And I got lovely mother and baby pictures later on that day. So that's an example of how in some clients where they have a relatively discrete trauma, panic attacks and anxiety can be treated very quickly. PTSD, again, you'll be familiar with all of the symptoms of this. I had a client, a lady in her late 20s. She was sexually abused as a teen. She had horrifying physical injuries after a suicide attempt involving a fall, a very large fall onto concrete. She was many weeks ventilated in ICU. She broke many bones, including her back. She had multiple surgeries, severe chronic pain, and she presented with frequent, what she called episodes of uncontrollable rage and violence against her partner. This was trigger off severe gut spasms that then trigger off 20 out of 10 nerve pain from a nerve injury. And she would have to call an ambulance and get admitted to hospital. She would have severe allergic reactions to just about every medication. she'd discharge herself from hospital, come home again and do it all again about 3 days later. She was, had a lot of mental confusion. She had severe gut problems. Her gut hadn't worked properly for 10 years. She couldn't evacuate her bowels without weekly colonics and massive doses of laxatives. And she was infertile and really wanting to have a baby. And after many sessions of havening, her PTSD is almost entirely gone. After 5 sessions of havening, she stopped having episodes. And she's now, a year later, just completed a master's degree and is a mother. So certainly she has some ongoing challenges in life, but it's a remarkable change. Pathological emotions. So I meet clients that are just filled with shame or guilt or grief or jealousy or subconscious anger. One of my clients, man in his 40s, a professional person with just a huge amount of suppressed anger, very unhappy, very anxious, a lot of social inhibition, a terrible skin rash on his wrists and the hands and knees and legs and face. And I could get no history from him at all. When I asked him about his childhood, he said it was fine. During havening, he'd get extreme rigidity of posture, extreme tension in his muscles. And we had to work for quite a while until eventually there was a cathartic release of anger. And over a number of sessions, I mean, he's been one of the longer term clients, really profoundly reshaped beliefs and his sense of self-worth. And his skin rash is now 90% better. And he's had some other therapies for that, but certainly the havening has helped. And somatization is where, as part of the encoded trauma, there's a whole variety of somatic symptoms can get encoded. The kind of client with chronic pelvic pain or vaginal secretions or dysmenorrhea or stuffy nose, pelvic floor dysfunction. I mean, there are some very bizarre symptoms like hysterical symptoms like blindness or paralysis that may be encoded as part of a trauma. So in the various cases I've seen skin rashes cleared up, gut function dissolved, drug allergies. The client with PTSD, she lost all her allergies to antibiotics, which is really remarkable because they were almost like anaphylactic reactions. One of my clients had been having 2 or 3 attacks of shingles every year for about 30 years, she told me. And she told me that since we've begun havening, she's not had an attack of shingles for 18 months. She also, we managed to cure her trigeminal neuralgia in about 20 minutes because it was very clearly traumatically linked. And a few months later, she got very stressed about the same trauma and it came back again. And in 10 minutes of havening, it was gone again. And I think she hasn't been bothered by that again. There are many case reports in the havening community of fibromyalgia being cured. And one of my trainees is a consultant immunologist and rheumatologist at a big hospital, and she's seeing lots of clients, lots of patients with idiopathic anaphylaxis. So anaphylaxis where they've no idea what the trigger is. And we have a deep suspicion that this might be a traumatically encoded response and that havening might actually cure them. So there's a whole variety of protocols within havening. You saw a demonstration of event havening. There's a whole variety of different ways. With early life trauma, there's no events that are remembered. They're not in conscious memory, so we work with emotions and body feelings. We do a lot of work to change core beliefs, to have people feeling worthy again. We can rewrite stories of someone that has a very difficult relationship with their father who subsequently died and everything was left unresolved. So we can do role havening and help someone relieve that conflict by bringing that person metaphorically into the room during havening and shifting beliefs. So it's, and many times I feel it's like time travel because, you know, someone who's had some really serious trauma early in life, it's kind of like we go back to the events and we delete that trauma. And we're not just deleting the trauma of that event at that time, but that trauma has affected their whole life. It's made them emotionally vulnerable, made them liable to re-traumatization. And when we go back in time and delete that trauma, it's like they have to recalibrate their whole life history and they can feel safe and loved. And that can have a really remarkable effect. And we can go forward into time and we can, what we call outcome haven, where we're going to create the desired future. So there's quite a wide range of protocols we use. Here are the science references for that you can look up. And if you're interested in havening training, I'm running a course just for doctors at the end of November. It's here in Raglan. This will be the first havening course just for doctors in the whole world. We've got 5 people signed up already. It's an intensive weekend training and a mixture of science and experiential learning, hands-on practice. If you want to become a certified practitioner, then there's a period of supervised practice, including writing up 30 cases. There's an online portal. There's a very rich international Facebook community where you can get to talk to the best therapists in the world. And all of the details of that can be found at my website, neuroscienceofhealing.com. So I'm going to just stop the screen share. So that's a lot of information all at once. But it's, I mean, to me as a doctor, this is the most astonishing and gratifying practice I've ever done in my whole life. It really is. And I've quit a career as an anesthetic specialist to do this full time as a practitioner and a trainer, and hopefully will get involved in some clinical research. So thank you all for your patience. I'd be really delighted to take questions. There's probably a lot of questions or observations if you want to ask about that case we saw on the video, on the wrong video, or if any of the science or any of the practical aspects. I'd really be happy to answer any of your questions now. So thank you so much for listening.
Thank you, Robin. It's Cressida here again. I just want to say a couple of people joined us late. Apologies if you didn't receive the email about the change of time due to daylight savings happening a week earlier in New Zealand to Australia. But please know that this has been recorded and that you will have access to a recording of this, and also that Robin is very kindly going to be circulating, or we're going to be circulating the slides from this from Robin as well. So apologies for the time problem. Now, I have a question first from Ros Priest. So Ros, if you'd like to unmute yourself and ask Robin, that'd be great. And then maybe I think Tim Ewer has a question after that one.
Yeah, hi Robin. That's absolutely fascinating, I have to say, the whole.
Hey, Ros.
Yeah, hi. Look, this is a very boring question, but I was having a bit of difficulty hearing the video, and I was just wondering if you can confirm what types of distractions you're actually just asking the client to do at the time, or do you have favourite ones or ones that are more effective than others?
Yeah, that's a good question. And I apologize for having completely the wrong video. I fully edited a version of the video with subtitles so that you'd be able to some of the words are a little indistinct. So in the beginning, this client was very distressed. I mean, I actually felt pretty ambushed because I'd agreed with her that we would do a demonstration, and I asked her to think of an event that wasn't too traumatizing. And when in front of an audience of doctors and therapists, she came out and said that she had a really major sexual trauma, and then became acutely distressed. Yeah. I felt quite discomforted. And I wanted to act quickly to reduce her distress. So we began the havening touch. So my first distraction was a completely neutral one, which was just to ask her to imagine that she's going into a supermarket or a superstore and she's filling the trolley with items starting from A to Z. So it was apples, bananas, cherries, dates, and so on. So it's a completely neutral distraction. And I just want to get her brain away from thinking about that horrible traumatic event. Yeah. Towards the end of it, when her energy is shifting, I was using other distractions where I was tapping into some of her happy memories. And I know she's a very spiritual person. And so I was asking about her happiest practices and other things. And there's quite a lot of laughter. So we got a whole variety of distractions we use. I have a poster kind of up on the wall to remind me. So a lot of them are neutral. It's like counting, imagining you're climbing steps and counting them. Leaving footsteps on the sand, doing backwards counting, subtracting 3s from 40, going A1, B2, C3. Tell us about your best holiday. Tell us about your favorite place where you feel calm and safe in your room, snuggled up in your bed with your cushions and your cat and your candles. So it's using positive association. So a mixture of really neutral distractions and ones that, you know, have a positive meaning for the client.
Yeah, great. Thank you. Thanks. That's great.
So next we had Tim Muir with a question.
Hi, Robin. Thank you again. That was a great presentation.
Thank you.
I've actually now got 3 questions, if that's okay, but you know,
Really?
given too much time in between. One of them is, do you use any breathing technique, or is it in terms of the actual physical processing?
No, not specifically as part of the protocol. So there are many practitioners who've used some breath work so they can incorporate that. So really whatever skills that you have to help a client feel relaxed and at ease and in their body, you can incorporate with havening, but it's not specifically part of the techniques. Although at the end, when I get to the end of havening and distractions, I usually get the client to just settle down and take a couple of big breaths and then get them back to the memory. But otherwise, I don't personally. So that's number 1.
Oh yes, number 2, you talked about distraction ideas and techniques. Do you use positive affirmations as well, or is that a separate thing?
Yes, so that's another technique within havening. So generally speaking, anytime that we've deleted something negative, like some trauma, it kind of creates space in the mind for something positive. And when the client's so full of delta waves, I mean, this is kind of almost hypnotic state that you're witnessing clients, that they're kind of suggestible and you can really shift beliefs. So pretty much every session I end with not just affirmations, but what we call affirmations. So we don't want to create too much resistance. So if I was to ask you to say, you know, I am worthy, I am worthy, I am worthy, a little voice in your head might be saying, no, you're not. So I get a sense of where they might be at. And so I might say, what if I am worthy? You don't have to believe it, but just think about the possibility. What if I'm worthy? And if there's a lot of resistance to that, then we take another step back and we say, what if part of me is worthy? What if part of me is worthy? And then if we can calibrate it right, we get a bit of resistance and we haven that away until they're saying that and it really feels true in that inner truth. Yeah, a part of me is worthy. So then we move on. A part of me is worthy. A part of me is worthy. And then if you sense a shift in energy, you might take another step forward and say, I am worthy. They might come to that, that sense of belief. So yeah, we play around a lot with beliefs. Yeah, there's I mean, we use techniques from NLP and so on. You can integrate lots of stuff. We use opposites sometimes. So if someone feels really shameful, we might haven ashamed, you know, innocent, ashamed, innocent, ashamed, innocent, or stupid, smart, stupid, smart. We just create an anchor. One of my clients had a very he'd have a flash of anger when little things would really irritate him, and he'd get extremely angry very quickly, like vacuuming in the kitchen, and the vacuum cleaner gets stuck behind the door, and he'd tug it, and it gets stuck, and suddenly he'd feel this rage, and really, you know, he had very severe trauma as a young boy. And what we did was anchored for him some opposites. So I thought, what's the opposite of irritation? I thought, well, amusement. So I got him to haven irritated, amused, irritated, amused, irritated, amused, irritated, amused, irritated, amused. And while havening, that creates an anchor so that when he starts to feel irritated, this idea of being amused pops up. And he came back the next week and said, this shit works. Because he hadn't been able to get irritated for a whole week. Because every time he started to feel irritated, he just burst out laughing. And another client with panic attacks, I did panic, safe, panic, safe, panic, safe. And then when she started to get a panic attack, this idea of safety would come up. So yeah, there's lots of playful things we can do. But yeah, affirmation is a really major part. Yeah. That's number 2.
Yeah, number 3 is, I noticed in the video clip that you were havening her in terms of the touch part, and it made me wonder, is that making it more effective if the practitioner, it's like the laying on of hands, there's some energetic exchange?
Yeah, so I think there's probably a hierarchy of effectiveness. So my belief is that the most effective is sitting very close and applying the touch directly. The next would be to sit in the room while the client sits on the sofa and does this, and you sit on the other side of the room and you do the same, but you're in the same room and you're energetically connected. and the third would be on a Zoom connection. So I've seen very effective havening by Zoom, but I find it a little fatiguing and stressful. Whereas the havening in person, I do 6 hour-long sessions in a full clinic day, and at the end of the day, I'm totally energized and got a smile on my face, and I'm sitting there in gratitude and awe, thinking, oh my goodness, this is just so amazing, and I'm more energized at the end. So it's applying havening to someone, you're getting the stimulation to your hands, so you're getting delta waves, and just as I'm havening now and you're watching me, you're getting delta waves through your mirror neurons.
And the fourth question I didn't mention. You talked about the 2 hertz, and I 1 to 2 hertz, and I understand the delta wave process. The speed in which you're doing that, is that, how does the frequency component come into that speed?
Yeah, good question. So the nerves that sense this soothing touch, they maximally fire when you stroke the skin at about 10 to 20 centimeters per second.
Okay.
This is all intuitive. I mean, this is just the soothing stroke. Massage practitioners move their hands at about this speed. So that's what creates the delta waves. So the frequency of the stroking is not the same as the frequency of the brain waves. But it so happens that this kind of soothing stroke causes lots of delta waves.
Okay, thank you. I better let others in, but that's great.
Well, I think you have special privileges. So,
that was interesting because you also answered the next question, which was from Thealissa. And Thealissa, if you've got something else to ask, just put another comment in the chat and we'll come back to you. But the next person was Nancy Huang, who had a question. So Nancy, are you there to put your microphone and video on?
Oh, hello.
Hi, Nancy.
Going on?
You're up.
Sorry, it's very dark in my room. Hi, thanks for that. Yeah, I had a question. So I just thought, I was struck by how there are similarities with a process called EMDR, where you also do the rate how how distressing something is and whether or not you believe a positive affirmation. I was just wondering if you could speak to whether or not the two are related or if they're quite different.
Yeah, so I mentioned EMDR just really quickly in passing. So the lateral eye movements creates a lot of delta waves. EMDR almost certainly works because of the generation of delta waves. Now, EMDR, like tapping, was an empirical therapy, so there was no scientific basis behind it. I mean, there were various theories. So it's most probable that EMDR works by generating delta waves. And we use lateral eye movements as part of havening, so as a distraction, because in itself it generates delta waves. The protocols are rather different because, I'm not an trained EMDR practitioner, but often, the client is kind of chanting about the trauma, whereas in havening we activate it very briefly and then we distract the client because we don't want that traumatic memory to be reactivated or reinforced. So all I can say is that among the havening practitioners, of which there are about 500 certified practitioners in the world, lots of them were EMDR practitioners, and they've all given up EMDR and they all do havening instead. And they say that havening works 3 or 4 times as fast as EMDR, but we still use the lateral eye movements, but the protocols are different.
Okay.
So good question, yeah.
So that's it for the questions. So if anyone else has some questions, Wendy Hamilton now has come in and has a question. So Wendy, if you'd like to come on, that'd be great.
Hi, Robin. Thank you very much for that. I was actually booked to do your course just before the first lockdown.
Yes.
I was very disappointed to miss out on that weekend. But anyway, I was just wondering, you didn't mention insomnia, and I was just thinking of cases where it seemed to be likely hypervigilance going on, that the person couldn't really relax and sleep deeply through the night. how might you sort of maybe use it for this if they couldn't connect to a specific trauma or something?
Yeah, I mean, it's a good question. And certainly havening appears to be very helpful when, as you say, the insomnia is due to high levels of stress or anxiety, hypervigilance. And in any case, if we take a very careful history and we're looking for those 4 components, those 4 conditions that must be met. And sometimes client tells us about an event in life that they don't regard as particularly emotionally significant, but we think, aha, that is definitely an encoding moment because you're recognizing the pattern. So if we find those, we delete those. But some clients with early life trauma, they don't have recalled traumatic events. So we've just got to work with feelings and emotions and body sensations. And we've got a variety of protocols for doing that. And what's curious is that as we begin doing that, over a number of sessions, more and more of the trauma rises up and becomes apparent, comes into memory, the early life stuff arises. There's a kind of unfolding. And we don't have to figure out how to do that because I tell each client, you have an innate healing wisdom within you that's going to govern the direction of your healing journey and how fast it goes. And I don't have to figure that out. We just kind of create this deep connection of safety and lots of delta waves and watch it kind of unfold. So I haven't had clients come specifically to me for insomnia, but I've had clients tell me that they haven't slept well for 20 years, and after the first episode of havening, they slept for 14 hours because we just completely changed their kind of brain state. So yeah, it's been the detective that's taking the history, it's looking for traumas. Clients will often deny them because they're actually not consciously aware, but it's amazing how quickly they just start to arise from the subconscious.
Yeah, lovely. Thank you.
So, Robin, I actually have a question for you, which is what kind of background training does somebody need to become a havening technician, practitioner?
Yeah, there's not actually this. I mean, havening is relatively new in the world. There's about 500 practitioners. We're really just beginning to put in place all of the kind of professional attributes around continuing professional development and standards and so on. So at the moment, there's not a formal definition of the entry requirements. So the majority of practitioners who come into havening are those who have an established practice. They're counselors, they're therapists, they're psychologists, they're hypnotherapists, they're bone therapists, they're naturopaths. They're people with skills in engaging with people and taking a history in sensing. But I've had one of my trainees had no background in any of that as well. She'd done quite a lot of yoga and breath work, and she had an extraordinary capacity to connect to people and bring that healing presence. And she's become a very successful practitioner, as a havener. So there's not a formal requirement, and it's really up to there's only about 30 trainers in the whole world. So it's up to us individually to assess, is this a suitable person? But any kind of health professional background really, or social work, there are lots of social workers, counselors, yeah. So yeah, I think over time it might be more formalized. There's a 2-year intensive training program, and then there's a process of supervised practice. And I'm coaching trainees with a very wide variety of skills. So one of my trainees is a burn practitioner, and she's extremely experienced. She's extremely observant. She's got this beautiful rapport with her client. She's very intuitive. She's doing amazing havening work as a trainee, and needs very little supervision. And others, a young woman who's got a degree in neuroscience on addiction, who doesn't have that therapeutic background, there's a lot of science knowledge, has need more supervision and coaching, but is now, doing extremely well. So, yeah.
So we also have a question now from Susan Anderson as well. Susan, if you're there to come online.
Yes. Hi, Robin. That was really
Hi,
fascinating.
Susan.
You mentioned that, you know, some people seem to get over their trauma after one session and some people need multiple sessions. Is there any way of predetermining where you know, how many sessions might be needed?
Yeah, so I think the first thing we do with every single client is make an assessment of the degree of emotional vulnerability. So if we look at the whole spectrum of kind of cases that I've seen in 2.5 years, the most vulnerable and most difficult would be someone who has extremely complex early life trauma, born with congenital malformations, a lot of surgery as a neonate and a toddler, a lot of parental separation, mental health problems in the family, and absent parent. I mean, a lot of really terrible early life stuff. And she came to me as a young adult, actually as a professional person, and she was frozen and dissociated. And she came into the room and she couldn't move and she couldn't make eye contact and she couldn't speak and she didn't know where to sit down and was literally frozen in the middle of the floor. And I had to direct her to a chair. She was not able to be touched and she couldn't do self-havening. So she was just frozen, dissociated. When I asked her to try this, she said, "My arms are frozen, they won't move, I can't do anything." So that's the most vulnerable. I mean, in her case, I sat on the far side of the room and just began doing this and began a 2-hour conversation. And I saw her energy shift, and after about 20 minutes, she was able to start self-havening. And it took 3 months. She doesn't live in this town, so I saw her intermittently. It was 3 months before I was able to apply havening touch directly to her, which was life-changing because she had no safety around touch from anyone ever. And you know, a year on, she's doing really well, but there's still residual trauma to be treated. So that's one end of the spectrum. The other end of the spectrum would be, you know, a professional person, business owner, very outgoing, positive, resilient, cheerful, capable. 10 years ago was in a car crash, stationary at a junction, speeding driver came through a red light, smashed into cars, spun her around. She got some whiplash, but wasn't injured. And ever since then, she's had a severe phobia of being in a car as a passenger or driver. So a 2-hour drive would be to Auckland would be a nightmare for her, really challenging and difficult. And she came into my clinic and she chose to do a self-havening touch. And in 10 minutes, we erased the memory of that car accident and her phobia was completely gone. So there's the whole complete spectrum. So, you know, I judged her to be a very resilient person with a lot of resources. So in my intake form, I'm asking people about things that are good in life, things that they enjoy, places that are safe. I'm seeking good resources to use in distractions, but also making an assessment of, you know, how resilient someone is or how vulnerable. So that's the major predictor. The early life trauma that's not recalled, that's pre-verbal, that's the most difficult to treat, and it's, you know, you're likely to be in quite a number of sessions. The recalled events, you know, the sexual trauma that happened at age 20 might be cleared very quickly, you know, maybe in one session. So, yeah.
Okay, thank you.
So we have the next question is from L. Likevy. Are you there, Elle, to turn your sound on, or would you like me to read it? I can read it.
Oh, yeah, no, that's fine. Thank you. I can do that. I'm not a medical doctor, but I am a bone therapist and a craniosacral work, and I also have been studying mental health. So my question was a two-pronged, really. One was, are any universities actually studying or looking into this approach or method? And the second one is, because mental health is such an ongoing concern now, especially with COVID, have any of the services like Beyond Blue or any of those sorts of people, do they have any awareness of this? And is it something that we could consider? Because it sounds like an approach that counselors and mental health workers could certainly benefit in using with their clients, and moving a little bit away from the pharmacological approach to dealing with people who, you know, who are often given a lot of medication. And not that there's something wrong with medication, but in terms of, you know, what could be used that is a little bit softer for people, I suppose.
Yeah, so good question. So, you know, today, havening would be regarded as a non-evidence-based practice, but the first randomized control trial was published on the 2nd of September, this month, just a couple of weeks ago, and 3 weeks ago, and that's got really striking results, and there'll be more studies published over time. So no, there are no universities teaching this. One of my clients who had an extraordinary response to havening happens to be a clinical psychologist and senior lecturer at one of our universities in Auckland, and she's very keen to get me on faculty. And yeah, her dean was really keen as well and wanted to give me an associate professor role, but unfortunately there was a scandal and he lost his post, and so my chief sponsor is. So I think it'll happen in time. I mean, I want to emphasize how new havening is. I was only the 2nd practitioner to be certified in New Zealand, the whole of New Zealand. 2.5 years ago, 2 years ago, there were no practitioners in New Zealand. There's quite a number in Australia. There's a good group there, but it's only just becoming into awareness of the different professions. It's growing much more rapidly now. There are only about half a dozen doctors in the whole world trained in havening. So other than Dr. Ron Rudin, who's the founder of this, I'm the only medical trainer of havening in the world. And that I've trained up a handful of doctors already, and the first training course for doctors will be at the end of November, which is unprecedented. So we're just gradually getting into the professions. In New Zealand, we have an organization called ACC, which is our National Accident Compensation Corporation. So anyone who has any kind of trauma gets all of their treatment paid for free through ACC, either surgical treatment for injury or psychological treatment, therapy, counseling. The ACC clinical advisors are not yet aware of havening, but I've been approached by a case manager who's got 127 clients with so-called sensitive claims, who wants me to do havening for some of her clients. So she's figuring out how I can get in as a kind of non-contracted provider and do some case studies. And I think gradually we'll get, so at the moment you wouldn't be able to get public funding for havening, but I think it will come sooner rather than later. So yeah, I hope we can get it into a university, maybe as a kind of diploma course. We certainly can get some more research going if we can get public funding for it. I mean, yeah, ACC spend billions of dollars a year on trauma. Havening is an absolute gift to them. And my client with complex regional pain syndrome, who was on ACC benefits for 8 years, is now essentially cured. I mean, they're going to be taking quite an interest in it.
Thank you for that. It's interesting. I think here in Melbourne, you can contact Dr. Sally at the National Institute for Integrative Medicine. They do a lot of research. They'd probably be very interested.
So you mentioned you were a bone practitioner. So one of my trainees is a bone practitioner, and she's very skilled at, looking at alignments and tension and so on. And she examines the client prior to havening and then re-examines them after an hour of havening, and she notices that a lot of the misalignments are resolving as the result of the havening. So it integrates very beautifully with different forms of body work. So yeah.
So we had another question following on from that from Nancy as well, if Nancy can grace us again with her presence.
Yeah, sorry, hi again. Just sort of another question, because I'm a medical student, so this is more like a question out of professional interest. I wanted to ask what the response has been from your fellow medical colleagues to your havening work, and how you found the transition from, I guess, like a biomedical framework to where you are now.
Yeah, good question. And during lockdown, I had a final year medical student staying at our house. We have a little apartment. And yeah, I took that opportunity to train her in havening, and she's just about to be certified as a practitioner just before she qualifies as a doctor. So in terms of the doctors, the smart thing is not to try to persuade anyone. So in my hospital as an anaesthetist, I just take it upon myself to use havening when I can. So for example, working a day surgical unit every week with the same surgeon, general surgical list, he goes to see the first patient to ask consent and comes out and says, "Oh, Robin, that first patient's really anxious. I thought you should know." So I go in to meet her. I discovered that she hasn't slept all night and she's practically having panic attacks about the idea of going into an operating room. And when I inquired into that 4 years ago, the last time she'd been in an operating room, she had a full-blown panic attack prior to anesthesia starting. So I came back out, I found the surgeon, I said, do you mind if I just delay the start of the list 10 minutes? And he said, no, okay, do whatever you need to do. I went back in, we did an event havening for that panic attack of the last visit to OR in 10 minutes. And then the orderly arrived to push her into the lift and take her up to the operating room. The surgeon witnessed her come into the operating room smiling and laughing, whereas, 15 minutes before. So, that's the best thing to do. Just let doctors notice. The local GPs in town have started noticing that some of their clients that were seeing them every week with a new symptom have just got better. That the woman had shingles 2 to 3 times every year, hasn't had shingles for a while. The trigeminal neuralgia is cured. The severe depression is gone. So I'll let doctors become curious. I'm excited that one of the medical practitioners coming to our training course is actually a professor of general practice, quite renowned. So he's been promoting the course through the GP network. So there's a lot of interest and curiosity, and I've spoken at GP conferences. So there's an openness, especially among integrative and holistic practitioners. I'm not sure we'll get too many orthopedic surgeons interested too soon, but.
So that seems to be it for the questions. If anyone else has something to ask, just unmute yourself and ask now, and otherwise we might begin winding up.
Hello. Hello, I've got a question. Thanks. I was just wondering about the training, Robin. Is it a standard training throughout the world, or is it individual from the trainers, how it's delivered?
No, so there's only one trainer's trainer, so all of the trainers have been trained up in a very standardized way. So there's a pretty fixed curriculum.
No, I mean, I'm interested in doing the training, and I'm in Australia.
Yes.
I noticed there's some opportunities with Dr. Rudin online,
Yes.
and your training is coming up this month, I think.
Yes.
That's what I mean. What is the first step for the training? Is it always the same?
Yes. Yeah. So
is it a weekend or 4 days or?
A weekend. So the standard training is an intensive weekend. It's either, during lockdown, there's a lot of the programs being provided online. I have some difficulties with that because I think this is a pretty sacred practice of human connection and presence. And,
yes.
And I personally would not like to try to teach online, but there are the online courses. There are trainers in Australia, so in Melbourne, Robin Elliott, who's a very experienced family therapist, is a certified trainer. She and I trained together as trainers, so she'll be offering training courses. Lockdown obviously has hit everyone. But yes, it's a standardized intensive weekend. Some people add a third day, and then it's that period of supervised practice with very intensive coaching and feedback. And the requirement to sit a simple science exam online.
And then certification comes after that. Is another training?
Yes. No, so there's no further training beyond the individual coaching from your trainer.
Okay. Thank you. Great. Thanks a lot.
Okay, so on that, I think we might start to wrap it up. Robin, was there anything else you wanted to say?
Just apologize for not being able to find the right video file, which is very frustrating because I spent about 3 hours carefully editing and just, making a 9-minute video, which with subtitles and everything else, and God knows where I put it on my computer. But I will make that available. I'll put it on by Mia and I'll password protect it. And when I share the information with you, I'll make that available because she's given permission for AIMA members, anyone attending this, to view that video. So that's, it's a 9-minute carefully edited and much better demonstration, and the sound will be better watching it directly. So I'll make that available.
Yeah, so that brings us to the fact that we will be distributing a copy of this video. So what I will do, Robin, just for everybody to know, is I will remove that section from the video, and I will just put a note that there's going to be a link to look at it in Vimeo with the password protections. That aside, everybody, thank you so much for attending this. I just wanted to say that AIMA relies on the support of our community to become members, to join our events and to do things like this. We also are really grateful for Robin for his amazing time and expertise tonight. So thank you so much, Robin. It was just a really fascinating and brilliant presentation. I also want to spruik Robin's book for him one more time. Robin has a book published called Time to Heal, Better Me, Better Life, through the astonishing new science of self-healing. You will all be being sent a link to how you can purchase that book should you wish to purchase 5 million copies of it each. And that's really it. So thank you everybody for attending, and thank you also to Joe Ewer, who does so much of the work behind this and just does the most brilliant job for AIMA. And so again, thank you so much, Robin.
Well, thank you, Robin. Such a good podcast. So, and thank you all for staying up so late, those of us in New Zealand, and not quite so late in Australia or other parts of the world. So, yeah, privileged to talk to you all. Thank you so much. Bye-bye.